care. This is one of the important session in palliative care. This session will be taken by Dr. Rajagopal. I hope all of you are familiar with Dr. Rajagopal, who was taking the first session on introducing palliative care for us. Sir, welcome back and over to you, sir.
Thank you. Thank you. Hello. Happy New Year, everyone. Where are the smiles? Yes. Very good. Okay. Thank you very much. Good. Uh, glad to see you all. And very appropriately, end of life care is coming last. I hope you all enjoyed the course. And we'll talk about this important subject. Raju, may I share the screen?
Sure, sir.
We all have done our profession in a certain framework. Many things that we used to do may deserve a second thought. During today's session, I want you to think about me as your patient someday. Like everyone else, I will also die someday. If I am lucky, one of you will be caring for me. What is it that you want to do? What's your primary duty of care to me? Is it to prolong life at all costs? Will you be struggling to keep me alive for as many days as possible on machines? Will your intention be to keep all my bodily organs normal, to make sure that the heart is beating, that the liver is functioning okay, the kidney is doing its job, and if I'm not breathing well enough, getting a machine to assist the process? Will that be what you will be doing at the end of my life? Is that the best thing for me? These are a few things that we will talk about today. But before I start, I want you to read these two sentences that one person by name Sindhu wrote in a popular Indian newspaper, The Hindu, after she lost her father in an intensive care unit. Who is going to read it out loud for me? Is everybody muted, Raju?
I'll read, sir.
Okay, very good. Please. Who is reading? What's your name?
My name is Sasi Sekhar.
Thank you. Thank you very much.
My
Please.
84-year-old father, my best friend, was enduring raw and intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors. His arms tied up, vulnerable and agonized.
Friends, thank you. Thank you very much for reading it out. That's not a whole article. I have given the link there. When Raju sends you the presentation, do please open that page and read the whole article. So, Sindhu's father did not want to be in an ICU, but the doctors said, no, your oxygen saturation is dropping. Our protocol says that you will be treated in an intensive care unit. Arms tied up, legs tied up, arms tied up because otherwise I might be pulling the tube out. So you tie me up. Legs tied up so that I don't struggle too much. Is that the way death should be? This was a poor patient whom we treated. She was very poor, and we actually had to pay the bus fare, send it across to her daughter so that she could entrust the children to a neighbor, leave a little money with the neighbor to feed them, take a bus and come over. But she died with a few drops of water going down the throat. And this is the way a doctor died. This is the way many people die nowadays. You see that his arms are tied up. There is a tube in every orifice. I want you to think, when my time comes, which of these will you encourage? Will you encourage these excellent facilities and machines and monitors and equipment in the ICU? Or will you facilitate this human touch and these few drops of water? Choose one for me. Okay, I won't force you to choose one for yourself. Choose one for me. These are the fundamental principles of medical ethics. You all know this? Have you either as part of your nursing education or during this course, did you come across these? Yes or no? Thumbs up if you have seen it. These are the 4 fundamental principles of medical ethics. 1, autonomy. This is my body. This is my life. No one else has more right over this than me. Are you willing to accept that? Raise your hand if you are able to accept this. Raju, I see no responses. I would like some responses.
Sir, Rokansino sister have raised her hand.
But most people are not sure. You are not sure whether this is my life and I have more right over this than you or the doctor. You may have 3 degrees. But this is my life. I am master of myself. Okay. Against my wish, you have no right to take me to the ICU if I am conscious. Against my wish, you have no right to intubate my trachea. Second, you have to do good. Doing good is your fundamental duty and my duty as a doctor. As a patient, I have the right to expect that from you, that you will do the best for me and that you will not do me harm and that what you do will be fair and equitable. Where the fundamental where the fundamental principles of medical ethics sorry, please bear with me. I want you to think and tell me whether, see Raju, I remember this group being more interactive than this on the first day. Hardly anybody is responding to me now. I think they are all scared of you. They don't want to unmute and speak because everybody understandably is absolutely scared of Rajalakshmi.
No, sir, I haven't done any harm yet.
Yet, so you're threatening. Sister Sushila is smiling. Sister Sushila, let me ask you. In the case of Sindhu's father, were the fundamental principles of medical ethics ignored? Sorry.
Mr. Sushila, can you unmute from your end and speak? We can't hear you. Unmute from your end. Yes.
Yeah, she's tied and kept. All her freedom is restricted. Like
Yes.
she's compelled to accept whatever others are doing for her. That is not good.
So he
We have
did
to
not.
respect her.
So as he says, is her father was being subjected to raw intrusive medical procedures against
Yeah.
his own wish.
Yes.
Autonomy was violated. His
Yeah.
arms tied up. That's not for his good, because the tubes are unnecessary. The artificial life support measures still put on a dying man as he goes out of his
Not
life.
necessary.
It's not good. It is actually not beneficial. It actually is only doing harm. Imagine the
Yes.
having to die with the imprisonment like that, and his wishes were not fair. So this is something that I want you all to remember. You and I are healthcare providers. What is our duty of care to the patient? This document from ICMR spells it out. The duty of the healthcare provider is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. Sophia, who else am I seeing here? Nuraisha, please remember, no medical ethics forces you to stretch out the dying process. You do not have the duty to prolong the heartbeat by a few hours. Your primary duty of care is to mitigate suffering, relieve suffering, cure sometimes, cure when possible, relieve often, relieve discomfort always, and comfort the person. And that is for everyone. So, ladies and gentlemen, your fundamental duty when I am the patient is to make me as comfortable as possible. When you know that I am dying anyway, when you know that you cannot cure me, when you know that treatment is futile, keep me as comfortable as possible, not only physically, also emotionally. Take a moment to think what you will do to make me comfortable emotionally. I may say, Sophia, I want to see my son again. And even at 2 o'clock in the morning, Sophia, I hope you will take the phone, ring up my son, and tell him your dad wants to see you. Because that's more important than all the nursing procedures you have learned. You have to ask yourself, what is it that I wish? Do I know what is happening to me? Do I know that my condition is not curable? And if I want to know, you have to be honest with me. Because if I am dying, I may have a few wishes. I may say, hey, I want to see somebody again. Please call my granddaughter. I want to see her once more. And I may say, sister, please send me home. I want to die in my home, in my bed. And you will have to see if it is possible. If at all possible, you will have to make it happen. And if I say, don't take away all these tubes, I don't want any of them, then you have to teach me and make me understand. But without them, you will have pain. You need this medication. Make me understand. Or you tell me, okay, these are things that we can stop, but these are things that you need. And where will I want to be? Have I talked to anybody? I have already talked to my family. I've actually put it down in a what we call a living will, saying that I do not wish to be treated in an intensive care unit. That if I can be kept comfortable at home, I would like that. If not, I shall be in a hospital where my family can be with me. Please respect those wishes. And whatever I want to tell you, please write down in the case sheet so that the next duty doctor or nurse will know what I want. Shall I stop for a minute and see if you have any questions so far? Are you with me? Do you understand what I am talking about? Do you have any questions? Raju, I am pausing for a minute to see if anybody has any questions.
Yes, sir.
If you have, you can unmute from your end and speak.
Or you can send a chat question if you don't want to speak. Or a comment. Day before yesterday, my colleague, Dr. Anandan, I don't know if you have seen him already, went to see a person with advanced incurable illness in his home, a person who is dying. He was getting about 9 medicines. One of them was somatostatin, the medicine to reduce serum cholesterol. What's the point of reducing serum cholesterol in somebody who is already dying? Another was to reduce blood pressure. Already he was not eating, not drinking. His BP was 90/60. He was still being given the blood pressure medication. So you will have to see many medications that the person ordinarily takes may become relevant at the end of life. Maybe the thyroid medication may have to be continued. Maybe the diabetes medicine may have to be continued. But whatever can be stopped, can be stopped. Let me ask you another question. So, if I am dying of an incurable illness, will you check my serum sodium every day? Yes or no? No. Okay. Noraisha says no. Your hospital protocol may force you to, but if you have any control over the matter, please stop. That's a joke. The serum sodium may be low. That happens ordinarily when people are dying. And that trying to correct it only causes more problem. And will I have to experience this difficulty of all my veins are collapsed, no intravenous line. So Sophia comes and tries here and here and here. And then somebody else comes along, Noraisha comes along and pokes here and here and in my ankle. When somebody is dying, venous access is difficult, it causes phlebitis. As far as possible, avoid intravenous lines. Most medicines can be used subcutaneously or rectally. And a few medicines that cannot be given subcutaneously or rectally are not useful in the end of life context. Hey, this is another, I don't know if some of you have heard about Parthasarathy show. He was former principal financial advisor to Prime Minister Manmohan Singh. He writes about the intensive care that his mother had. Who is going to read it out for me? Please unmute and read
I
it.
will.
Nurusha?
Even on the day of fasting, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was in the negative.
When the Parthasarathy show says day of passing, what he means is even on her date of death, the doctors advised a liver function procedure. And he asked, will that help? They said, no. But this is our protocol. We will keep doing it every day. What's the point? Another poke into the body of a dying man? Continue, please, sir, continue to read.
Female, female and male nurses hurried about pushing and shoving the inert body, robbing any peace, contemplation or prayer. Where was palliative care?
So you see, we need to think.
Very
Many
sad.
things that you do in a curative illness lose its relevance. When you are the matron, maybe you can change some rules. Many things that we usually do becomes meaningless. A time comes when you don't ask what is the BP because it is not relevant. Instead, ask how is he? Ask how is he comfortable? When a new nurse joins our team, I always find this. If I ring up at night and ask, hey, how is Mr. So and so? They will say, if they are new, they will say, sir, his pulse rate is 84, his BP is 160 by 100, and his breathing is 16 per minute. But after the first month in palliative care, they will say, sir, at the moment he is sleeping. He has been fairly comfortable. He did not have his dinner, but he did take half a glass of fruit juice. These may be the things that we will care about. And they may say, his family has come, they are with him. Those are the important things. Now, if I am on my last day, please think, will you still be giving me 2-hourly skin position change? Even on the last day, I do not want to have a pressure sore, but the 2-hourly restriction may become irrelevant. Don't change my position if I am finally sleeping after 16 hours of being awake. Maybe you can postpone it a little bit. You can postpone it if you give me an air bed. Then you may not have to do it every 2 hours. Maybe it can go on to 4 hours if I am sleeping. So put comfort as the primary goal and talk to me. I may look unconscious, but assume that even if I am unable to talk, I may be able to hear. Before you turn me to a side, please say, Uncle, I am going to turn you over to the other side. Uncle, I'm sorry, I have to give you this injection. It's insulin. See, even when you are not sure whether I am conscious, it's important to tell me because very often I may be unable to express, but I may be listening. And a needle coming in when I am not expecting, when I am half conscious, I may react with anger and suffering. and do communicate to my family. They will be anxious. Remember, they'll be suffering with me and they need a bit of support. And especially if there are children around, please talk to them. If a dying person's young son and daughter are there, please talk to them. Ask them, do you have any questions? Do you understand what's happening? We are going to do the best for your dad. Those few words of kindness and explanations to the children will help them to cope. Very often, children are given no explanations at all, and they live in great fear, and their minds may become disturbed forever. If I believe in a religion and my family believes in a religion and I want some rituals, please make it happen even in the hospital. If your faith is for the person to be read Bible to or Bhagavad Gita to or Quran to, whatever that is, those rituals must be facilitated. What the person believes in, not what you believe. Your faith may ask you to read Bhagavad Gita to everybody or Ramayanam to everybody. By no means do that if that is against the patient's religion and wish. As far as possible, no one should die alone. People should have company, loved ones. Just think, at that point of time, what is important to me when I am going? What do I have now? Raju, will my position of chairman of Pallium India help me?
No, sir, it won't.
And my car, my mansion, my new home that I don't have one, but if I had one with a swimming pool, is that valuable to me? Remember, the only things that are valuable to me at that time, apart from physical comfort, is the love that I am able to give and the love that I will get. And unfortunately, precisely that is stolen from patients by our hospitals. That is not correct. The family should be there, touching the person, doing whatever they want to do, maybe rubbing the hands, and maybe just holding your hands. That can be so much more than any of your medication at that time. And remember, the family members themselves are suffering. Convey to them with your eyes, with your body language, that you care for them. And if you ask me, I have no doubt, I certainly do not want this electronic nightmare of an ICU. I want a human touch and a farewell with some compassion. Thank you once more. Please read that out. Raju, who was reading it for me earlier?
Sister Noorsha.
Yes, please again. Futile means useless. Yes.
Futile and inappropriate artificial life support measures usually cause physical, psychological, and social suffering to patients and families. Palliative care is the human.
Oh, sorry.
It's no problem.
Palliative care is the humane
Humane.
alternative. Humane.
So, futile and inappropriate artificial life support measures like ventilator, renal dialysis, etc., cause physical suffering, psychological suffering, social suffering. The humane alternative, compassionate alternative, is to give them palliative care, which is what you all now will be able to give. And if you allow somebody to die a natural death, don't think that is euthanasia. You all understand what is euthanasia? Mercy killing. So if you stop the ventilator and allow me to go, allow me to die a natural death, will that be euthanasia? Please read again, Sister Noresha.
Euthanasia is the intentional act of killing a terminally ill patient on voluntary request by the direct intervention of a doctor for the purpose of the good of the patient.
We are not doing that. Please do not confuse this. Stopping a ventilator in an insalvageable situation is not euthanasia. Euthanasia is when you deliberately wanted to end a life. Here, allowing natural death is not euthanasia. Everybody has to die. No human being is immortal. People have to die. And allowing that death is not euthanasia. I hope that is clear. Does anybody have a confusion over this? And as the ICMR says, Indian Council of Medical Research clarifies, the term passive euthanasia is a misnomer. It's obsolete terminology. Should we avoid it? Because euthanasia cannot be passive. Euthanasia, if you remember, is the intentional act of killing a person. So it cannot be passive. What we are doing, if you stop a ventilator or you stop a dialysis, is only allowing natural death. So if patient is already on artificial life support measures, like a ventilator, then what can we do? One, you must ask, what did I want? Have I left a document saying what I want? Indeed, I have. You ask my wife and she will give you the document. I have said that I do not want my death to be stretched out on machines. But you also have to the responsibility to make sure that it is not only one doctor's feeling that treatment is futile. Several doctors in Indian court decision, 3 doctors independently have to evaluate me and say, this life is not salvageable. And then don't immediately stop the life support measure. Listen to the family. Answer their questions. And we don't want the family and you to be in a conflict. We have to be on the same side. How do you get on the same side? Don't start preaching to them. Get them seated. Make them sit down. And convey empathy. How will you convey empathy? Listen, you now think of the situation where the person is dying in the hospital and you have the family there. You bring them out into the waiting room. The family is sitting around them. How will you open the conversation? Who do I see now? People who have not spoken. Shivagami? Sunaina? Who wants to speak? How will you open that conversation? How will you start that conversation? Suppose you do this. I see that you are going through a very difficult time. We are here to help you. You want to do the best thing for your father. We also want to do the best thing for him. Let us talk about it. That will be conveying the empathy. And now you will not be arguing with each other. You will be working together. It's not always possible, I know. Sometimes they are angry already. That's to be expected. But whenever possible, this is what we attempt. We shall offer them only realistic treatment options. We will not tell them, okay, if we were in the United States of America, maybe this trial could have been possible. What's the point? Give them only what is locally available. Allow time. If you say, look, I don't think the ventilator is helping him. I think we should provide him palliative care, but take the ventilator off, keep him comfortable. And the family may not be able to take a decision immediately. So continue what you are doing. Maybe you will continue non-invasive ventilation. We don't want the family to live in guilt, feeling that they have killed their father. And here is one important point. Everybody, please listen. Never say there is nothing more to be done. It is not true. There is no situation where nothing more can be done. There is always something you can do to hold a hand, to wipe a tear, or to provide more pain relief, provide symptom control. No situation where nothing more can be done. If you tell the family there is nothing more to be done, they will be wondering, if you can't do anything, then I will take him to another hospital. Instead say, though we don't think his life can be salvaged, we will continue to do everything to keep him comfortable. That would be our words. And in every hospital, this is one room that must be there outside the ICU or every ward, a counseling room, a place where you can sit down with the patient's family, sit down with the wife or children or husband and talk to them and listen to them. They will cry a little bit. Maybe you will hold a hand. You may be too busy to do that, in which case you may be still able to spend 2 minutes. Those 2 minutes are precious. And I think in end of life care, the natural sequence from a critical care unit or ICU to a high dependency unit or step down ICU would be a palliative care unit. Now, let me also, before I finish, tell you about advanced medical directives. I don't know about everybody's country, but India does not have a law covering in end of life care. Many countries have. India doesn't have one. So what we go by is a Supreme Court judgment of 2018. Advanced medical directives are things that I have written it down. I have written it down saying I do not want this and this and this. I want that and that and that. And if now that I have signed a document, expressed my wishes, I name a trusted person to take surrogate decisions on my behalf. That would be my son. You and your doctor have the ethical and legal duty to respect my wishes. The Supreme Court also has laid down several procedures which are complicated, but leave alone that. The most important thing is the primary duty of care cannot be forgotten. The duty of care, what is the duty of care of the healthcare provider? To mitigate suffering, to cure sometimes, to relieve often, and to comfort always. That's the duty of care. If my family and you are on the same side, there will be no conflict of opinion. There is no question of legal complications. You just document everything. Say that this is what the person wanted. This is what the family said they are agreeable. And under the circumstances, we have decided to provide this person with palliative care and to stop aggressive life support interventions. And that palliative care would mean pain relief, treatment for breathing disorders, respiratory distress has to be treated, and generally comfort measures. I see that we have some 20 minutes for discussions. Would you like to? I will, Raju, if during the discussion I have to go back to the presentation, I will reopen it. But for the time being, I would rather see the participants and talk to them. So, based on what I have said so far, and based on your personal experiences, what do you think? Do you have any questions or comments? So, Imiangla, I said that no active interventions are required. Then we can stop investigations. Unnecessary inventions are not good. Shashi Shekhar seems to be agreeing. So questions and comments, please. I am conscious that how many participants, there are 54 participants here. What I have said may have been very painful things for some of you because you may have gone through similar things in your own family. There are 54 people, I am sure at least 5 or 10 would have such experiences. If you want to share an experience, please do, but be briefly. Every comment has to be limited to 2 minutes, but you are welcome to share your experiences and please ask questions.
Sister Sushila?
When patient is dying, that time the relatives feel that person, that the patient is becoming a burden to them. So I think being present, the relatives especially being present to them is very important. Because patients that time, the agony they going through of dying, they fear and anxiety. So when they feel that their relatives are close by, they will feel more comforted, more than any other treatment.
Yes. Sister Sushila, you are absolutely right. As I said, at that time, presence of the family is the most critical thing. Most of the time, people are loving and care for the family. But as you say, sometimes their relationships may not have been such, and the family may be exhausted financially, socially, emotionally, and may not be there. So, if the person is dying and no family member cares enough or is available to stay with them, what's the alternative? What is the alternative? Who do I see? Jabarth Daimari. I'm sorry if I am not pronouncing your name right. Sorry.
At least to make them to speak over the phone,
Yeah, if possible, certainly.
video
But
calls.
Sister
Now,
Sushila, there is another thing that we can do. You can give them love. That we do not talk about love usually in medicine and nursing. I don't think any textbook of nursing will have a chapter on love.
you know,
But human love is so precious. And when you, though you are a very busy nurse, find time to sit there for 2 minutes and hold a hand and ask, Uncle, I hope you are comfortable. Please let me know if I can do anything for you. Then he will say, my own family has deserted me, but you are a daughter to me. Thank you. Or he may say, I thought God had deserted me, but he has not. He has sent you as an angel. So getting the family together is what we usually do. Works 99% of times in our case, may not be so everywhere. But if a family deserts a dying person, nobody can replace them, but we do our best. At that moment, you become the son or daughter or the friends to hold their hands and to give them support. In the case of the woman, Sister Sushila, that I showed you the picture, she was in a poor home. It's a home done here in my city, run by a church. The daughter, the daughter had a drunkard as a husband. She had no money. It's not that she didn't care, but she said, I cannot come because who will feed my children if I am also not here? So we actually had to find the money to send her so that she could come. But we made it happen. Is not the nursing science that you have read in the textbook? But you are not only a nurse. I am not only a doctor. You are a human being also. I am a human being also. Sometimes we have to shake ourselves out of our uniforms and become human beings. Because primarily, you are a human being first and a nurse second.
Sir, that I have an experience that when I was doing my nursing in Father Muller's Mangalore, uh, daytime I was doing the duty in one general ward, and one lady had no attender. Though she had five children, nobody could come and stay with her in the ward because of their family responsibilities. So daytime I was a staff, nighttime I was an attender for her. So that just now what you said, same words she told me, and there was not a stool also. I used to sleep under her bed and just watch over her, wash her clothes, feed her, and morning get up and go for duty.
Sister Sushila, I am folding my hands to you. There is God in you. I really don't have to go to a temple or a church or anywhere to see God. I see God in people like you. Sunaina has written a note. Sunaina, do you want to unmute and speak? I have seen nurses not behaving. Yeah, please, Sunaina.
Yes, sir. I have a personal experience. Like when my uncle, he was admitted in hospital. Though I'm a nurse, but still the nurses, he was in ICU and he was on his deathbed. Still the nurses didn't behave well with my auntie and his. They wanted to see him and touch him, but they did not behave well and they did not allow them. It's like they said, you cannot go, he's on ventilator, and he died. They were trying to meet him, so I really felt bad. Even I requested them. So I really want to share this thing and request others to not to behave like that with the family.
Sunaina, thank you for sharing that. I'm sure nobody in this group, people who are caring enough to come for a palliative care training, would not dream of doing that. But this is sometimes something that science does to us. My medical science and your nursing education tends to convert you to a human machine. No, family is not allowed. Family is allowed only from 4 to 5 p.m. Why?
Yes.
Why on earth do people die only between 4 and 5 p.m.? That's inhuman. And these are things that you and I and everybody has to change. How will you change? You can model the way. The change will not be overnight. But when you talk about it, when you demonstrate love and compassion and care, people change. Cheesy Young, you want to, you have shared an experience. Do you want to read it out or do you want me to? Chi, a patient. Yes, Chi. Duodenal cancer with gastric outlet obstruction post-tending, deep jaundice, hepatic encephalopathy. After discussion with patient and wife, decided to stay at home. But after pressure from relatives, wife sent patient to hospital, was dialyzed. The wife has hope that patient will get well, but the patient passed away after 2 weeks. After meeting up with patient wife and after patient passed away, she expressed no regret of sending patient to hospital. I was thinking, is that decision correct initially? Look, after the patient is gone, there is no meaning in infusing guilt into the wife. Let her believe that she did the right thing. That's okay. Because if she feels guilty, it is a burden for her to carry forever. But let us first look at it from the patient's point of view. The patient and family wanted to stay at home. Family pressure took him for dialysis. This commonly happens. So, in that initial discussion, what I usually do, I'll tell you. Okay, they say, okay, we will do the best for him. We'll keep him at home, etc. Then I tell him, but there is a challenge. Your cousins and your uncles and aunts will come and they will say, we are keeping him at home. Don't you want to spend money? Take him to hospital. Then I'll tell the family, you have to decide one thing. Whatever pressure comes on, decide that you will do only what is best for your mom, for your dad. Not because others tell you something. If you are in doubt, call us. We will help you to take decisions. Despite all this, sometimes these untoward things happen. That is natural, but we have to try our best. Sophia, you want to read out your question or ask it in your words?
My question is, how we want to explain to patient. For example, my patient now, she's having CA-breast, now already jaundice and weak, but her son want to do tapping. How to explain to the
What tapping? What tapping? Peritoneal tapping.
peritoneal tapping? Yes.
Yeah. So, Sophia,
Mm.
so the first step is to decide what is the best thing for the patient. Ascites can make the patient uncomfortable. Tapping the ascites may actually make him easier to breathe. He will not be breathless, he'll be able to sleep. So even if he seems to be close to death, some procedures we'll do. If there is an ascites that is tense, we'll tap it. If there's a pleural effusion, we'll tap it. We will not put in a tube and artificially ventilate him. So procedures may still be done if it is for the comfort of the patient. But suppose the family says, no, also please do the dialysis. Then that is the time, Sophia, the answer to your question is, if I am very busy, I'll say, hey, I can't talk now. Can you please come at 12 o'clock? Please go and get a cup of coffee and come back at 12. When I have some time to spare, I'll sit down with the man. I'll tell him, Sophia, I will not start by telling him, your dad will not be helped by this. Instead, I'll say, you are a very loving son. I can see the pain on your face. You want to do the best for your dad. Sophia, now I am on his side. Till then, I am somebody arguing with him. You can't win arguments at that time. Why is he saying he wants to do the tapping? Because he loves his dad. I see that you love your dad very much. I also want to do the best for him. Let us talk about it. And he may say, can't you see his abdomen is so tense, he can't breathe. And then you will say, we'll tap that ascites. We'll make him comfortable. And what else do you want to do? Doctor, I heard that his kidney is failing. Can't you do dialysis? Then you may say, doing dialysis will not be a comfortable procedure for him. It will not improve his liver condition, and anyway, he unfortunately is not in a condition where his quality of life can be improved by dialysis. It may cause him more suffering than this. That is how we will explain to them. We have only a couple of minutes more. I have one long comment here from Imiangla. There was a patient who really wanted to go to a higher center and to travel to another city, even during this COVID situation, even though it was said to be futile and the family members were well aware of that. They still want to comply to his wishes. In that situation, instead of withdrawing the unnecessary activities, they did the opposite. I think this was also acceptable. At the same time, how do we approach such patient in order to give the best care, best for the patient as well as for the family? You are thinking from the patient's point of view. The patient may be in denial. He may not be able to accept that he cannot get cured. You have to ask yourself, Imiangla, whose life is it? It is his life. He has the absolute right over it. And you will say, of course, you will have to do whatever you think best. But maybe you are having several questions. Sit down. Let us talk about it. What exactly do you understand about your illness? Do you want to talk about it? And then he may ask several questions. But Yamiyangla, if in spite of all that, he still wants to go and try a liver transplantation, it is sad. It will not give him comfort, you know. But you will have to abide by that. It is his life. So long as he is conscious, he has the right to take decisions about his own life. But what you can do is to be there. And as he leaves the hospital, I will still tell him, look, I wish you the best. If you need our care, please feel free to come back to us. I will not close the door. Hey, ladies, thank you very much, and gentlemen. Thank you very much for that active discussion.
Sir, we have one another question too from Rosma.
From Regina, not a question. Regina was just saying good morning. Good morning, Regina. Rosma, Raju is allowing me to answer one more question. Thank you, Raju. How to explain to patient's family if they insist to bring back the patient who is on end-of-life care to village or remote area with no medical access, yet breathless and journey by land will take 6 to 8 hours. True, Rosma, these things happen. The patient himself will not be able to fight. The family may have several reasons for doing this. It may be their faith. Actually, there's something else happens. Raju, I don't know if you know this. Sometimes the family wants to take the person alive because once death has occurred, the ambulance costs more. They have no money. Poor people. So, Rosma, if the patient's wish can be fulfilled, we will do the best for him. But here, if the family is deciding otherwise, we have no choice. We will have to, what you will do is to give him such medication as to keep him as comfortable as possible during the journey. That's all you can do. You cannot always do everything that you think is for the best of the patient. Remember, autonomy is the patient's right to take decisions. And if the patient is not competent to take decisions, the decision falls on the family. You will have to abide by that and try to make it as comfortable as possible for the person. Thank you, everybody. Thank you for that discussion. Thank you for your questions and comments.
So can we move on to the case presentation?
Yes, please.
Okay. Sister Zing.
Hello?
Yes, sister, we can hear you.
Oh, okay. So good afternoon, everyone. I'm Chi Ting from Caris Hospice, Penang, Malaysia. I was actually a palliative care nurse for only about 2 years. My connection might be unstable sometimes, so if you lost me, please let me know. So today I'm going to present this case. 80 years old male, advanced cancer of pancreas with lung, liver, and peritoneal mets. Presenting complaints, vomiting on and off small amount, especially after meal. Second is constipation, also having somatic pain over umbilical region but unable to describe or specify location. The fourth complaint is oral thrush. Next, history of illness. In October 2019, he was actually presented with decreased appetite, went to routine follow-up in a hospital, but was told that everything is normal. So in April this year, complaint of abdominal distended. Did OGDS, but nothing abnormal was found and was sent home. A month later, he complained increased abdominal pain. So CT scan was done and was diagnosed cancer tail of pancreas with peripancreatic and retroperitoneal lymphadenopathy and multiple lung and liver mets. So patient and family opted for palliative care due to old age of patient and was referred to hospice on the 31st of May this year. Next. On examination, patient is alert and comfortable, ECOG 2 to 3. Vital signs are normal, able to ambulate around the house with a walking aid. Pain over umbilical region is reasonably controlled with current analgesic regime. Vomiting on and off, especially after meal, but manageable with oral antiemetic. Complaint of abdominal fullness, especially after meal. PR was done, was half full with hard stool. High enema was given, but no result. Next slide, please. Treatment and significant investigation. For the constipation, we increased the Dacolax to 2 BD and continuous syrup, lactulose 10 ml on night if tolerated. But doctor also will give higher enema if patient BNO for 3 days. For somatic pain over the umbilical region, he was on Transtec patch 35 mcg during clucking, but switched to fentanyl patch 25 mcg on second visit due to constipation, and continued aqueous morphine 4 mg for the breakthrough pain. Vomiting on and off, minimal vomiting during the first and second visit, manageable with oral antiemetic, and advised to go on a liquid diet only. Next, So during the third visit, he was actually having persistent vomiting for about more than 5 times per day, with greenish vomiters, especially after meal and also throughout the day, which is likely due to high intestinal obstruction. So our advice is actually advise patient to go to hospital to explore on any possibility for any surgical intervention, but then was told by the surgeon no option for surgery. We offered a nasogastric tube insertion at that time for venting purposes, but patient refused. So with that, we actually started him on this continuously subcutaneous infusion Maxalon 30 mg over 24 hours, and also advised to go on liquid diet as tolerated. So with this subcutaneous infusion Maxalon, his vomiting actually reduced to 1 to 2 times per day, and able to tolerate liquid and occasionally soft diet. Sometimes he also eat a few grapes. To him, pain is not an issue at that time. His symptoms are under control for about 3 weeks before condition worsened. Few days before patient passed on, his abdocolic and episode of vomiting increases. So we switched from subcutaneous infusion Maxalon to Buscopan 40 mg and increased fentanyl patch to 37 mcg. And with that, patient is sleeping most of the time with minimal intake. Vomiting was decreased and pain is reasonably controlled. He passed away peacefully at home after 2 days. Next slide. Psychosocial aspect. Patient is married with 1 son and 1 daughter. Wife is a dementia patient. A patient is staying with his daughter and worked as a church pastor before. Emotional aspect. He actually understands and aware of his diagnosis and prognosis. So he is fully acceptance of his disease. And for him, most important for now is not to suffer in pain. And he said he's ready to be with the Lord anytime. And patient's preference for end of life will be at home. So the medication he was on is Transtac patch 37 mcg, omeprazole 40 mg OD, Maxalon 10 mg TDS, Motillium 10 mg TDS, Ganaton 50 mg TDS, syrup lactulose 10 ml BD, Doclex 2 BD, and Revin Inima BNO for 3 days, and then fentanyl patch 25 mcg, and then to 37 mcg. Medication for his high intestinal obstruction is a subcutaneous infusion of Maxalon 30 mg, which subsequently changed to Buscopan 40 mg over the 24 hours. The main concern during our care is persistent vomiting due to high partial intestinal obstruction, constipation, stomachic pain, which is the abdominal colic, which worsened towards the few days of life. Next slide, please. Summary. So this is Mr. T, 80 years old, recently diagnosed advanced CA of pancreas with lung, liver, and peritoneal mets, complicated with high intestinal obstruction, was under the care of hospice about 1 month before passed away peacefully at home. His main issue during our care is persistent vomiting, which is reasonably controlled after commencing subcutaneous infusion Maxalon and subsequently to Buscopan. Pain abdocolic is not an issue initially, although increasing towards the end, but is well controlled during terminal phase. Children is beside him when he breathed his last. So next slide. Discussion points to be discussed is what and how to advise, especially on diet when patient was a food lover but unable to enjoy food for now. How to advise patient and family member regarding nutrition towards end of life. Is NGT insertion for venting purposes necessary for this patient? Is there other ways to manage patient symptoms, especially during end of life? And that's all from my presentation. Thank you.
Thank you, Sister Z. Anybody need any more clarification regarding this patient story? Otherwise, we can move on to the discussion points. No, sir. Okay.
Oh, I thought you were going to lead the discussion. But sorry, Cheng is from which country? The person who presented the case?
Malaysia.
Sorry, Malaysia. Okay, okay. Penang. Okay. Congratulations on a excellent management of the person, of this person. How to advise on diet? the person loves food. What happens here? There is an obstruction. Initially, with your maxalone, that's metoclopramide and ganetone, you are trying to overcome the obstruction. Try to push the food past the obstruction, and you were successful. With that, vomiting became less, and the person started consuming a little bit. What would you advise the person to have is the question. The person cannot have a lot because he will vomit. So a little bit. What should it be? Will you get the dietitian to come and order the best high calorie food that is possible? What would you ask the person to have? That is question. That's the question she has given me. But instead of answering the question, I am asking you all, to everybody, what do you think is the best food for the person? And Noresh asks, can ask him to chew only, then spit it out? Noresh, rather than answering that question, I will go to the question behind the question. What you are asking is, what you are saying is, he's a food lover. He wants to enjoy his food. Enjoying the food, maybe tasting and spitting out may not be the best for him. As Imiangla says, whatever he prefers, whatever you will explain, like to explain that look, we are giving you medicines, food is being pushed out of the stomach, but your stomach now will have only a small capacity. You can eat only a little bit. If you eat solids, you are more likely to vomit. What? But it is your choice. There is no sense in restricting, no, you cannot have this or that. Would you like some soup? That may be the best for you. You say, I don't want soup, I want that. Maybe in which case, try a little bit. Some people are happy just to chew it and spit it out. Most people are not. Because enjoyment of the food for them is not only in the taste buds, it's also in the act of eating. So it will depend on him. I'll give him whatever he wants to after explaining to him that if you take hard solids, you are likely to vomit more. You will have to take a very little at a time and then allow him to do what he wants to. Shashi Shekhar, liquid food might be the best for him. Semi-solid he may tolerate. But that is his choice. If at that time he says, I want to eat laddu, I would give him laddu, even if he's a diabetic. Maybe he'll eat a little bit. That is his choice. He may vomit. Yes, we'll have to accept that. Small meals at regular intervals, says Regina. True. But here, when there is an intestinal obstruction, the regular interval may not work because for you and me, the gastric emptying time is 4 to 6 hours. For that person, it may be 12 hours. So rather than that, here the purpose is not nutrition, it is enjoyment of the food. When he feels he would like to take something, we will give it. So towards the end of life, one of the discussion points given is how to advise the patient and family regarding nutrition towards the end of life. Listen, at this point of time, we are more worried about his enjoyment of food than the calories. I'm not keen on pushing calories into him now. His enjoyment is most important. Hey, what do you think? Is the nasogastric tube insertion for venting purposes necessary for this patient? Does everybody understand the question? Venting is just to drain it. Teisnio says not necessary. It depends, Teisnio. Sometimes their abdomen feels bloated and they find vomiting very distressing. And very rarely, though rarely, sometimes people like it when it is drained out so that they don't feel bloated anymore. Again, it depends only on comfort. Most of the time, we avoid a nasogastric tube in that situation. The management described here is exactly what I would do too. Try to offer metoclopramide, try to push the food past. At some point, when it doesn't work, it causes colic. Stop the metoclopramide. Give buscopan to quieten the abdomen down. Now the intake will be even less. That's okay. If there is distension and he says, very uncomfortable, then an nasogastric tube can be tried. And if he says, I don't like this, please take it out, I'll manage without it, we'll take it out. I even had one patient, he would eat what he wants to, he would drink whatever he wants to. And then he himself would push in an nasogastric tube, empty it out. He didn't like it to be kept there. He will take it out. That was okay with us also. That's rare, but most importantly, it is the person's comfort now. Nutrition matters less. Calories matters less. It is the patient's comfort that matters most at the end of life. Are there other ways to manage patients' symptoms, especially during end of life? If our communication is starting early and the patient understands what he has or what she has, then we will work with the person. Most of the time, I will do exactly this. As far as possible, overcome the obstruction, not only with metoclopramide, but also with corticosteroid, which will shrink the tumor because the edema will be treated. And then they may be able to take a little bit of food. That is the best thing. But later, the metoclopramide may cause colic, in which case exactly what you gave, buscopan, hyacinth butylbromide. You have more expensive options, but this is what we use most often. So we use that and quieten the person, quieten the abdomen. And if necessary, towards the end, the person says, I want to sleep. You may add a sleeping tablet. Allow the person to sleep in comfort. Are there other ways to manage patient symptoms? They have already tried that. They tried whether a surgical procedure was possible. But as far as symptom management is concerned, I think I would also go by what was done in this case. Are there any other questions? Raju, did you say that this was their last session?
Yes, sir.
Is this the day when you take some feedback?
Yes, sir. At the end, after the session.
Okay. We have 10 minutes more, and the questions seem to be over. So, points from today's session. Raju, 1 minute by the clock. Not pronouncing your name correct. Comfort of the patient matters in ULC. It matters at any point of time, but in end of life care, the patient's comfort matters more than anything else. Good, important point. Yeah, the second, Sanobar Aisha Bindi also says the same thing. Best for comfort. That's one major learning point. Okay, who else is going to speak? Okay. Autonomy is utmost important, Imeyangla. Provided adequate explanation is given. Hey, that's very important. Imeyangla, thank you for pointing it out. Autonomy to be uh, to be effective has to be coupled with adequate empowerment. Imeyangla, thank you for making that very important point. Unless a person has adequate information, how can he take the right choice? Thank you. Provided adequate explanation is given and discussed as a team. And the team, the most important team person in the team is Imeyangla. Who is the most important person in the team?
Patient.
Yes.
Patient,
Second
sir.
most important, family. Yes. Very good. Shashi Shekhar, give time with people when patient is going to die. Absolutely. Give them time with the family. Manage. Hey, Raju, can you save the chat comments, please? Management of end of life care, especially how to handle different case. Comfort care is important. Okay, thank you, Rosma. Sunaina, proper care and comfortable death instead of giving several tubings and making it uncomfortable. Absolutely, absolutely, absolutely. Out with the tubes and more on with the comfort. Uh, comfort again. Rashmita also says comfort. Michelle says comfort. Autonomy also needs to be considered. Care and love is the more effective than just medication. Care, love, care, love. Thank you, Michelle. Nancy, autonomy. Add life to days, not days to life. Thank you, Nancy. That's a good, excellent quote. Comfort again from Chi. Autonomy. Caregivers' well-being should be considered too. So important, Chi. Thank you very much. The family is suffering. They may be arguing with you, they may be fighting you, but they are suffering. Uh, understand patient rather than forcing him or her to take medicines. Yes, it doesn't work. Forcing him means they'll say, yes, 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 give it to me. They'll keep it under the pillow. We miss every day. I think what Shashishekar says that many of these things are missing in ordinary everyday practice. So what are we going to do about that, Shashi? Shashi, we have to change the way things are. You and I and everyone here has to talk about it. Say, this is not right. What we do to dying people is not right. And we have to be agents of change. Don't underestimate your own power. I'm not asking you to go and fight with your medical superintendent, with your nursing matron. But be gentle, be persuasive. Willie, comfort care. Do not force them to eat. Be with them. Be with them when they are. Be with them. Hold their hands. Wipe a tear. Be a human being. You are not only a nurse. Primarily, you are a human being. Uh, more comfort and loving care is from Shirley. Thank you, Shirley. Kiran Bala. Decision making for the patient at the end of life, when we as healthcare worker might think not doing justice to a patient, when family have to go through different aspects of suffering like financial, manpower, etc. True. We can think only medically and nursing science. They have to think of everything. Thank you. Shashi, thank you very much. Human touch is important. Imiangla, having the loved ones with the patient at the end of time is very, very important. If no one is available for them, we have to be there, being present. Thank you. That's a very nice quote to end the session with. Thank you, Imiangla. Just because you have several nursing degrees, because I have a medical degree, doesn't mean that we are not human beings. Sometimes we can be human beings more than nurses, and being there with the person, giving them love, to be there, being present. Raju, wasn't that an excellent? Oh, listen, all this time I was struggling to see who was the facilitator with you because I couldn't identify by the eyes. Eyes are not visible. Now I know it is Shiva. So, Shiva, Raju,
Yes, sir.
this quote from Imiangla is a perfect closure for the course. We have to be there, being present. Thank you.
Sir, one more thing. So self-care is also very, very important while we take care of dying patient.
What do you do about that, Shiva?
We can
Imayangla goes and stays with a dying patient, being there, being present. And then the next day, Imayangla feels miserable, cannot sleep. What can Imayangla do? Share.
Yes.
When you are emotionally upset, you have to share with your friends and colleagues. You cannot be an island. You don't take all the troubles home by yourself. Talk to your friends. Share between the team. The team has to be there for one another. Because very often when we get to know them, and on the last day, they tell their story. Their story is a pathetic story of how he or she was abandoned by the family, how they work for the family and now nobody wants them. And then you feel so sad that somebody has to die that way. You have two choices. You can be happy that you could be there for that person at that moment, or you can be sad that this person died like this. When you are feeling sad, go and talk to your friends and look out for your friends. And if tomorrow Imiangla's friend is looking absolutely miserable, maybe you will have to sit down with that person and say, "You don't look very happy today. Is there something that you want to share?" So being there for everyone. Shiba, thank you very much. That was a very important point that you brought up. And Jenny says autonomy is important. They can write how to advance directives. That's what the term, Jenny. When they are conscious, you can help patients. You can do it in your own home, to your grandparents, your parents. Talk about this. Talk about how patients die. Talk about advanced directives. Thank you very much. Raju, there's an article written by our Gina in the Hindu about how she talked about end of life care to her parents. Maybe we can share. I'll send you that article link. You can share it with everybody.
Sure, sir. We will send it.
Okay, thank you. Oh, sorry, members were there for that. We were making memories, taking lots of pictures, videos, and fulfilling Dad's wishes. He passed away on the 30th of November, 2020. The experience is only a month old. This must be a very painful time for Ajana to sit here and sit through these 1.5 years. Ajanu, all of us are with you in spirit, sharing your grief. But I'm glad you have some pleasant memories also when you think of your dad. Thank you, everybody. Thank you.